Is going to run through once again the standardized approach to reading a chest x-ray. So recall that we said that the first thing to do is to do an initial survey and then run through and look at specific structures within the chest, so skeleton, mediastinum, hyla, lungs and pleura, and then the soft tissue. So we're going to walk through that here real quick. So with the initial survey, one of the first things that you want to do, in addition to looking for obvious asymmetries, foreign objects, etc., is to look for what we call RIP. So rotation, inspiration, and penetration. So rotation, it means that the patient isn't perfectly aligned with the detector, and so as a result, you're going to get some asymmetries as a result of that. And so you can think, it's easy to be tricked into thinking that that is pathologic, but in fact, it's actually just because they're not actually perfectly perpendicular on the PA film. So the key there is to look at the clavicular heads and note the distance between the left and right clavicular heads relative to the spinous processes of T1 and T2. So usually I just look at T1 and then go over and look at the distance to the left and right clavicular heads, and if it's approximately equidistant, that means your rotation is not there. So there is no rotation. Inspiration, again, remember that the patient should be inspiring, and so as a result, you should be able to see 5 to 6 anterior ribs and 8 to 10 posterior ribs at the midclavicular line. And then with penetration, this is just saying that you should be able to make out the thoracic vertebrae just barely through the heart, and that means that it was an adequately penetrated chest x-ray. So that has to do with the amount of voltage that's used when the x-ray is being shot. So if we look here at the ribs, you can see the 6 anterior ribs that are visible here. So again, this is the first rib. You can see it arching around anteriorly. You can see rib 2, 3, 4, 5, and 6 there. But again, what I mentioned earlier about the first thing to look for in terms of rotation. So here you can see the clavicular heads, so one on either side. And then here are your spinous processes, right? So that tells you that's the midline. And again, you can see that they are approximately equidistant from the midline. So that tells you again that this patient is not significantly rotated within or rotated relative to the detector. So a couple other things that you can appreciate on these chest x-rays are the position of the fissures, so the oblique and horizontal fissures. As I mentioned in one of the prior videos, the horizontal fissure, which is represented by this dotted line here, is at approximately the level of the fourth rib. So once again, if you count down the ribs, you'll see the fourth rib, and that's the approximate location of the horizontal fissure. Whereas the oblique fissure is going to typically be found in the fifth intercostal space, and it'll end right around the level of the sixth rib. So you can see the sixth rib, the anterior part of the sixth rib coming around right here. And again, that oblique fissure on the right side is approximately in line with that sixth rib. And same thing over here on the left side. You can see fifth intercostal space and then coursing around approximately in line with the sixth rib in that individual. But again, keep in mind that in many cases the fissures will be invisible, but you do still want to keep in mind that you should be looking for them on any chest x-ray. So going back to the skeletal structures again, we already mentioned the 6 anterior ribs. So looking at the 10 posterior ribs, remember you can usually see 8 to 10 posterior ribs on a typical chest x-ray. So again, you can see the first rib up here, and again, remember you're going to see it arching down and around. Here's rib 2, again you can see it arching down. 3, again there's the anterior part of it. 4, 5, 6, 7, and then again you can see 8. You don't see here you actually can see part of the 8th rib there. There's the 9th rib down there, and then there's the 10th rib going down that way. And I think on this one, if you look really closely, you can also appreciate the 11th and the 12th ribs there as well. So again, this is obviously a very good chest x-ray for viewing bony landmarks. And the way that the x-ray tech takes the image, they can adjust the voltage in order to be able to better appreciate the bony structures versus some of the soft tissue or lung structures. And so when you look at the soft tissue throughout the lungs, the pulmonary cavities, you'll notice that again there's kind of these white streaks that you see, and these are all pulmonary vessels. So again, you should see more pulmonary vessels inferiorly, and less sort of smaller or what looks like fewer of them more superiorly, just because the size is dramatically less superiorly in the lungs versus inferiorly in the lungs, and that has to do with gravity. So again, this dotted line right here represents the full course of the second rib. So just to kind of get you comfortable with being able to follow that, those ribs in their entirety. And then the numbers here all represent the anterior ribs. And then in this individual, you can actually just barely make out the horizontal fissure. So you can see that, again, it looks like just kind of this little line coming across right here. So you can see how challenging it can be to accurately identify that horizontal fissure. And then in this individual, this is where you have a normal anatomical variant. So the arrows here represent cervical ribs. So you can see here's the first rib coming around, and you can see these sort of additional, almost look like enlarged transverse processes on the C7 vertebra heading down inferior laterally. But in fact, this is a cervical rib bilaterally in this individual. And they are usually bilateral in most people. All right, so in this one, again, you want to first start by looking at the clavicular heads, and then relate that to the spinous processes. You'll notice that this person is slightly rotated to their left, because you can see how the spinous processes are a little bit closer to the left head, clavicular head, than compared to the right. And in this person, there is actually an abnormality that is pointed out here. So that's going to be a small nodule in the right lower lobe of the lung. And in the same individual, though, you have to be careful because that's the approximate location of the nipples. And so in this case, the nipple shadows are identified with a marker. You can see one there and one there. And so that's oftentimes done if there is concern that might be that is unclear to the radiologist whether that's the nipple shadow or not. This is one way to get around that. You can put these nipple markers on the patient to be able to better visualize a true lesion versus just a shadow from the nipples. And so here, this is an example where the two arrows here are pointing out nipple shadows. So you can see how they are in approximately the same location as those nodules, and so that's where it can be helpful to have the nipple markers used in imaging. So here we have another image where there's once again another nodule, not to be confused with a nipple shadow. So you can see that pointed out here by the yellow arrow. And so now we're going to talk about lateral chest x-rays. So there's 5 key areas on the lateral chest x-ray. So it's going to include the retrosternal space, the hilar region of the lung, again, sort of this area right here, the fissures of the lung, as well as the thoracic spine. So again, you can clearly see the thoracic spine right here, and then the diaphragm. So you can see the left and right hemidiaphragm in this image. So remember, the right one you should be able to see coursing the entire distance, and the left one's eventually going to disappear behind the silhouette of the heart. And then finally, this image doesn't show it super well, but you can, if you look closely, you can see right here the costodiaphragmatic recess or the costophrenic sulci. And remember, that's where you're going to have fluid accumulation in an upright patient. So in the case of a pleural effusion, that's where you're going to expect to see blunting of the costodiaphragmatic recess. So we'll look at that a little bit closer later on. So here the retrosternal space is circled. The hilar region, again, the dark black you see right here, or the darker region, that is going to be the left main stem bronchus. You can see the right main stem bronchus right above that. And then all the white sort of surrounding this is representing the pulmonary vasculature, the pulmonary arteries. And then these lines both represent, again, I'll move back and forth just so you can try to kind of appreciate the oblique and horizontal fissures. So the place where I think you can see the oblique fissure the best is you can see kind of this line cutting across right here. So that represents again, that oblique fissure, whereas the horizontal one, again, quite a bit harder to appreciate there, but that's the approximate location of it. Thoracic spine, you'll notice that it's going to appear lighter superiorly and become progressively darker as you move more and more inferiorly. The reason for that is because you have fewer and fewer structures that are occluding or impeding the course of the X-ray beam. So in this case, what's happening is with the scapula up here superiorly, that's why you get this really light appearance, and the humerus as well is going to be to some extent causing the upper part of the thoracic spine to be light, whereas down here where you don't have other structures impeding the X-ray beam. That's where you get a much darker thoracic spine. And then again, finally, you can see the left and right hemidiaphragms right here, shown quite well, and then the costodiaphragmatic sulci or recesses located right there and there. And then just to end with a couple more additional points on the hyla of the lung. So here we have, again, a left lateral view of the chest, and so you can see the hilum outlined right there. You can see the heart shadow, the retrosternal space right here, retrocardiac space back here, and then again the costodiaphragmatic recesses down there. And so this is just another view of a left lateral chest X-ray to help you appreciate some of the various structures. So again, the circle here is representing the hilum. The line here represents the oblique fissure. And then you can see obviously a nice representation of the thoracic spine. Notice how the upper and lower borders of adjacent vertebrae should be parallel to each other. So again, you want to always make sure that you appreciate the thoracic spine. You can see the intervertebral foramina here through the image as well. And then once again, you can appreciate the left and right hemidiaphragms coming across on this image here as well. And so then this is a hilar mass in this example. So this is where you have obviously a very significantly different appearance to the hilum on a left lateral chest X-ray than you usually do. And so this is the kind of thing that would tell you that obviously something's not right in this, because you don't see that normal pattern. You can't see a nice dark structure here, which is going to be representing the left main stem bronchus. You really can't appreciate the right main stem bronchus very well. And again, you just have this large mass of hyperintensity, which is representing the hilar mass in this case.